Yes, so our recording just started. So going through our agenda quickly today, we've got a packed agenda. Stephen will start us off by talking about the fiscal year 2022 spending floor data that we've received thus far. And then he'll go over a new guide document we have ready for everyone. And then I'll talk about the community benefit program changes. We'll have a 10-minute break. And then we'll get into the meat of the meeting, which is talking about the narratives, the OHA report on the narratives, and the new legislation that we have. And then we'll reserve 10 minutes at the end for a question and answer and public comment. So if anyone does have a public comment they'd like to make, please chat either Stephen or myself, and we will tally those up to make sure that we reserve time for everyone at the end. Or if you'd like to submit written comment, we can also definitely accept a written comment and post that on our website later if you aren't prepared to speak right now. But either way, we'll have plenty of time for a question, answer, as well as public comment. So today we have some OHA staff here. We're joined by our leader, Trilby DeYoung, who is the Health Policy and Analytics Division Deputy Director. Within our division, Piper Block is our Research and Data Unit Manager. Within our unit, Stephen Ranzoni is the Hospital Reporting Program Manager. And within our program, I'm Sarah Gravy, and I'm the Hospital Community Benefit Program Coordinator. And we also have Rachel Higgins, who is the Community Benefit Research Analyst. So now I'd like to hand it over to Trilby to make some opening remarks for us.
Thank you so much, Sarah. It's a pleasure to be here today. I'm really glad that I have the opportunity to kick things off and speak for a few minutes about the importance of Oregon's Hospital Community Benefit Program. I had hoped to be with you all last year and had a conflict, but this is a program that I've had the opportunity to work on a bit. Really proud of what the staff have done here and really pleased that there's so many folks who've joined today and are interested in helping us maximize the impact here. People on this call already know that OHA's strategic goal is to eliminate health inequities in this state. And clearly, we can't achieve that ambitious goal or make meaningful progress toward that goal alone. The investments that you all are working on through this program are critical to forward progress. This program is just such an important piece of moving forward. We've learned that in order to make progress against health disparities and particularly health inequities, we need to encourage investments in the community that reach priority populations and that are responsive to needs those populations have identified. And hospitals are in those communities. Your organizations have really been planning and working with community groups, representing and serving priority populations for some time now. So hospitals really represent an understanding in many ways of what it takes to collaborate and what it takes to meaningfully address social determinants of health in the different communities we have across the state. And we want to capitalize on that history, that understanding, that work with communities. In short, the action, the investments that you make with this program are a super powerful lever for positive change. And we intend to really highlight your successes in this area. And you'll hear a lot more about that in the discussion about the narratives. We'd also like to benefit from learning about the challenges that you all are encountering and digging into the program data to really understand trends. So you'll hear more about that today as well. Part of what I've seen in the slides and in the data that the staff have shared with me is that while community benefit amounts continue to increase, the numbers are largely due to hikes in unreimbursed care. And Medicaid shortfalls, Medicare shortfalls, really reflected through subsidized health services spending, are making a significant contribution. You'll hear discussion today of opportunities for more proactive spending that can ease the burden on people in your communities. I mean, as you well know, ease that burden of disease and injury and help people stay healthy enough to avoid hospital care altogether. We're hoping to hear more from you all about what kinds of mechanisms you think would help increase this type of spending. Perhaps increased collaboration with CCOs, whose HRS spending really aligns with this program in terms of the prioritized needs, the service areas, the strategies, and increasingly collaboration between hospitals in the same ownership system or even across systems where you're sharing service areas, where these combined investments would really have greater impacts than each hospital working alone. So thanks so much for being here today, and thanks in advance for working with us to better understand investments you all are making and to maximize the impact of this important program. I'll stop there and we can get into the meat of this. Thanks, Sarah.
Thank you so much, Trilby. That was great. Okay, I am going to build off of what Trilby said and talk about the purpose of this meeting. Community benefit today, we're going to look at three things. We're going to talk about our policies and procedures. We are going to use this meeting to look at our first data that we have about half of it incoming so far. And then we're going to discuss and present ways that we can prioritize and incentivize social determinants of health spending. So really the point of the Oregon's community benefit program is to move community benefit to be purposeful, planned programs that address health needs through the social determinants of health. And community benefit spending is critical to OHA's strategic goal, which is to eliminate health disparities. So by administrative rule, following House Bill 3076 in 2019, addressing health disparities was added to the definition of community benefit. So really that health equity and addressing health disparities is integral to community benefit, just as it is to the state's strategic goal. And both goals here, community benefit and the states, were created through community input. And so we really want to put the focus on that community benefit, or community input also directs hospital community benefit spending. So let's start it off with Stephen talking about our FY 2022 spending floor data.
Thank you, Sarah. Can we have next slide, please? By way of introduction, my name is Stephen Ranzoni. I use he, him pronouns, and I am the program manager of the hospital reporting program here with OHA. And so what I'm going to do right now for you is I'm going to review some of our most recent and timely data. And by doing that, I do want to very highly stress an important caveat in interpreting this data. And that is, based on our reporting timelines, the data you're about to see only include 33 hospitals that have reported their FY22 community benefit data to date. And so that does not include any hospital that has a calendar year, fiscal year. So when their 22 year ended there on December 31st, we do not have the data for those hospitals yet. It's not due to us until August. All the trends thus only include those 33 hospitals. So when you see those previous dates, it is the same 33 hospitals for our analysis. So I just want to make that perfectly clear. Secondly, just because of that, this data is preliminary, and so it's not final. Obviously, we go through more thorough review when we have the completed year. We allow hospitals to double check their amounts, make sure everything lines up. And so that is really important when I make this next statement. Based on the data that we have so far, 22 of the 25 groupings as stated to us on the CBR3 forms have met their assigned spending floor in FY22 from the data that we have today. And so the key trends that we have seen thus far in this data is, first, is total unreimbursed care increased 33%. And that's in comparison with a 14% increase in proactive spending. I'll talk a little bit more about what we mean by those categories. Subsidized health services, a type of unreimbursed care, has increased 74%. from fiscal year 21. Unreimbursed Medicaid itself increased 29%, 29% from fiscal year 21, and charity care increased 4%. Next slide, please. Thank you. So this looks at the totality of unreimbursed care. Again, those categories of the unreimbursed Medicaid, the charity care, the subsidized health services, and other public program. Please note this is a double axis graph. I know it's not most ideal, but a succinct way to do it. And so our axis on the left-hand side, as you look at it, is the dollar amount. The axis on the right-hand side is the percent change year over year. The blue lines just trending the dollar amount increase. The green bars are the year over year change from the previous fiscal year. And so as you see highlighted in this trend here, there is a really big jump in FY22 among these 33 hospitals, well in excess of any trend that we've seen before, which, you just kind of eyeball an average, hovers around about 9%, I'd call it. We basically tripled that going into FY22. And so a very significant jump in those amounts. Next slide, please. This chart breaks down those categories of unreimbursed care into their components. And so you can see at the bottom, and again, we are going to send out these slides just to let you know, so don't stress too hard about, looking and capturing everything. These cluster charts are showing the relative contribution of each component of overall unreimbursed care. And so we've got subsidized health services in the dark blue. We have unreimbursed Medicaid in the orange, which you can see is the preponderance of the money here. In the green is charity care. And in the lighter blue is the other public program. And so again, you see, even as the growth happens, the driver of the growth, the contributing factor overall truly to that 33% that I said in the beginning for the total unreimbursed care really lies with unreimbursed Medicaid. I don't want to dismiss subsidized health services. It has grown tremendously for sure. As we stated earlier, it's up 74% year over year. But the bulk of the dollars is associated with unreimbursed Medicaid. Next slide. So total proactive spending increased 14% year over year compared to FY21. That's down slightly from the previous year in 2021, where it increased 15% from 2020. However, the money's growing, the trend's going, and I think overall this is definitely the positive trend. This is the trend line we want to highlight. This is the growth that we want to see. We like these numbers here. These are good numbers, and so growth here is positive. Next slide. Just like we did before, this chart breaks down the individual contributions to what we call proactive or direct spending, and so as you can see, the categories there are at the bottom. The dark blue is community health improvement. Orange is research. Green is health professions education. Our lighter blue is the cash and in-kind contributions. I'm going to call that a sage green is community building. And the red is community benefit operations. And so again, the preponderance of money that is in this category is associated with health professions education. The preponderance of that does come from OHSU as well. When you want to look at wide models, OHSU is a state year, so they are in this data, just by way of pointing out trends. And so areas very specifically the OHA in terms of addressing health equity, as we've spoken to before, that work to address the social determinants of health are largely going to be captured where we see cash and in-kind contributions in community building. Right, so that lighter blue and that sage green that sit next to each other as small blocks, and so that's the area of focus that we as a division are going to want to work to promote within these spend categories. Next slide, please. So what does that all mean amongst these 33 hospitals? This trend, or excuse me, this table here shows the aggregate spending floors that we assigned and that we have assigned to date. So in FY22, in aggregate across these 33 hospitals, we assigned roughly $833 million spending floors across all these hospitals. FY22, it increased to 868. So what this means is we've taken a fairly tremendous jump in assigned spending floors. And so out the door spending floors for FY24 that just recently became final is just over $1 billion. And then up a little bit more in 2025. That equates to roughly a 24% overall increase when you compare this cycle, FY24, to FY22. And so we'll point out that we have several hospitals that saw their spending floors double or more than double compared to FY22. And each and every one of these cases, it was always associated with a very tremendous growth in unreimbursed Medicaid. And so I think stepping back, that we can't necessarily address the root causes. We've seen a couple things that maybe point to it. We definitely know these are years that goes across the pandemic period. We also know that these are years that we're going across a period of time of tremendous expense growth in the hospitals, particularly as it relates to payroll and contract labor. And so we have questions about the sustainability of this growth and what it really means. Are hospitals going to be seeing the same level of unreimbursed care when we actually start getting data in 2024 as the trend suggested? So I think these are some open questions for us as we analyze the data. The one thing that I will point out is across these years, when we compare the growth in unreimbursed care, it is substantially more so than the growth in relative gross charges. And what I mean by that is unreimbursed care costs reported to us grew at a higher rate than the growth of the underlying gross charges, right? And so actual cost to deliver Medicaid apparently increased. And so that's what you can derive from that understanding, as stated to us in these reports. One thing that we pointed out, and I'm going to be fairly succinct when I say this because I don't have a lot more to say about it other than this, is we've observed on our new reporting form lots of situations across several hospitals where hospitals are claiming their provider taxes without coming back and offsetting their QDP revenue. I don't know. One disadvantage we're at right now is that we know this information because we started a new reporting form. Hospitals only were required to use this reporting form in FY22, so I don't have historical data to go look at. I don't have a lot of trend. I don't know if this is a change in previous reporting or behavior. I just can observe it now in this year. And so this is something that I think that we're going to work in the future to provide guidance around, so we can be sure that we're getting some appropriate reporting of these expenses, because without offsetting QDP revenue, it definitely is a source for many hospitals to potentially be greatly increasing their expenses as it relates to Medicaid. Next slide. I'm going to pause here. Actually, you could probably go back a slide. Sorry. If there's any questions, you could raise your hands. I'll give it a second on that data. There are no questions. Oh, Trilby.
This is more a comment than a question, Stephen, but I'm thinking about, imagining the future and what these trends will look like, and the fact that Oregon's taken a really significant step forward to increase coverage with the Healthier Oregon program, and which will now mean that Medicaid is available to people who otherwise would have been ineligible because of their immigration status. So this is, I think it's brought some 40,000 people over already by launching this program this summer. And hopefully we will see some impact from that in unreimbursed care. But just wanted to flag that for folks. It's really exciting, and hopefully we'll make a positive difference in these numbers.
Yes, absolutely. Raymond.
Thank you, Stephen. I'm representing Southern Coos Hospital in Bandon. We are a 21-bed critical access hospital. We have several members of our team on the call today, and thank you so much for having this. Our concern is that as a small critical access hospital, our spending floor is scheduled to more than double, go up 61% year over year, from $1.3 to $2.2 million next year. That is unsustainable for our small hospital. We operate at an operating loss as it stands right now. We're going to be in a position where we're going to have to choose either meeting our community benefit requirement or keeping our doors open. We will choose to keep our doors open.
Yeah, and thank you for the comment. And I appreciate it. We've seen, of course, through state year hospital, state year reporting. What that means is every health district hospital in the state has reported to us, and a lot of our very small hospitals have reported to us. And they're the ones that I think, as an outlier, have seen some of the largest growth in spending floors. And so I think just in direct comments about the sustainability of your spending floor and any issues that you may or may not have in getting it, absolutely please reach out to us in the program, reach out to Stephen or Sarah, me, or Sarah. And we're very happy to talk about it. We're very happy to discuss your trends, and we're very happy to go over the options that you have with your spending floor. We have policy set out for modification of it. We have had hospitals in this cycle reach out to us. We have modified spending floors already. And so it's something that we can and will do. So thank you for that. Eli.
Thank you. Appreciate that.
Thanks, Stephen. Was the 4% charity care growth consistent across hospitals, or was it more a reflection of a couple of outliers, like an increase with OHSU's charity care?
I don't, off the top of my head, I don't have that because I just did some aggregate trends for this thing. I could probably answer that specifically and get back to you. And I think it's a great question, honestly. I just don't know right now. Thanks. All right, no other questions. Move on. Kind of changing gears. Next second. I'm going to do this pretty rapidly. I'm going to showcase a new document. This is just a guidance document. We're going to be sending it to all the hospitals every year. This is going to talk about all the reporting that your hospital is obligated to make to our reporting program, the hospital reporting program. We have noticed, of course, I'm sure everybody here is aware, there's been a lot of turnover in hospitals, a lot of administrative staff coming and going, a lot of institutional knowledge leaving with that. And so we're hoping to, on a fairly annual basis, send out a document, and what you're about to see is posted on our website and will be sent out to every hospital here. It's just going to basically summarize what you have to do to meet your reporting obligations to OHA. Excuse me, I should say the hospital reporting program. Another big caveat is this is not inclusive of every single thing in the universe you may actually have to report to OHA. So next slide. Next slide. And so what we'll do, hospital, I don't know if it's unique, but in Oregon, I think it's unique. We have 5 different fiscal years operating in the state, running from as early as April 1 and going all the way through a calendar year. And so because of that, a large portion of our reporting, all our audited financial reporting and everything to do with community benefit, comes on a fiscal year basis. And so the first thing that we're going to provide for you, particularly as it relates to your obligations for reporting community benefit and audited financial and things that are keyed on a fiscal year, is we've got kind of a timeline flow chart here that's going to designate when you have to report things to OHA keyed on when your fiscal year starts. And so, we begin with this as it relates to spending floor, no less than 90 days prior to the start of your odd number fiscal year, you need to tell us how you want your spending floor assigned to your facility. That's that CBR3 form. That's where, particularly if you're a health system, you're going to say, assign me a floor for all my hospitals as one, give me individual floors. We need these clinics in here, et cetera. Then we'll designate for you. Again, I'm not going to go into details of every single one of these boxes because you'll get it and you'll be able to review it. But we'll talk to you about the obligations in this form, about when things are due as it relates to the spending floor guidelines, when you're going to get a draft letter from us, the time period with which you have to respond to that draft letter, when that letter then has to become final to us. And so, and then other reports as they're due to us, such as your audited financial statement, which are due 120 days after the end of your fiscal year. and your community benefit forms, which are 240 days after the end of your fiscal year. Next slide, please. And so here's just a nice summary of everything that you need to submit to OHA. And so annually, this is not a fiscal year one. Annually, every single year by June 30th is the hospital facility and clinic report form. This is a new form. It is still causing confusion. This is the third year that we've collected it. This was authorized by House Bill 3076. This is the form with which hospitals essentially just designate their clinic structure. So they say, you know, whoever is operating under this name of the hospital, here's every clinic that is owned or operated by us or operating under the same brand. And this is whether or not they are for profit. We collect these forms and we post it on our website. We put it under the hospitals in our hospital profile page so the public can look up who is associated with who and understand what clinics may or may not be nonprofit. Based on fiscal year, 120 days after the end of each fiscal year, your audited financial statements, the actual PDF of the audited financials that your third-party, accountants have made for you needs to be submitted to OHA. And then a summary of those audited financial statements, a hospital-specific one, the audited financial reporting form, Form FR3, is due to us as well. 240 days after the end of each fiscal year, your community benefit reporting form, Form CBR1, is due to us. And new starting in FY22 is the narrative, your supplemental narrative report due to us, and copies of your most recent and relevant community health needs assessments and community health improvement plans. And then, as we mentioned before, no less than 90 days before the start of an odd number fiscal year, your minimum community benefit spending floor grouping worksheet designating how you want your hospitals grouped is due to us. And so we got a message that came in, and it does relate to what we just talked about. The question that came in via a chat is, what happens if a hospital doesn't meet their floor? Nothing. I mean, we will publicly report that. Sarah's going to talk about what we're going to be doing when we're reporting our community benefit data and minimum spending floor data here on the second half of our presentation. But in terms of statutory, outcome, there is no penalty, civil or otherwise, for failure to meet your spending floor. Just the simple conversation about it and the public disclosure. Next slide. Back to this document, everything that we just talked about, this is put into a chart that gives some fairly accurate dates. It may or may not flex ever so slightly based on a leap year, based on your fiscal year. So, if your fiscal year is a state year ends 6/30, generally speaking, your audited financials and FR3 forms are due there at the end of October, in and around the 29th. And so we'll distribute that. Next slide. So we have a couple of things that are due to us that come courtesy of a vendor, that vendor being Apprise Health Insights. So on the 23rd day of the month, your data bank, which is your self-reported financial data, is required to be sent. So it's the 23rd day for the preceding month. You need to make your data bank submissions to Apprise Health Insights. 90 days after the close of each calendar quarter, your hospital inpatient and emergency room discharge data is due to Apprise. Dates there below. And then administered annually, I think is generally there in the fall and winter time. The American Hospital Association annual survey is due. That's actually important. That is done. I know a lot of hospitals kind of are like, oh, why are we doing this? We actually use that to fulfill some statute reporting obligations as it relates to some facility utilization research. And so we used to submit we used to have, you go back several years, we used to have a completely different reporting form. Hospitals had to fill out extra and redundant information. We made a decision several years ago to just pull the data that we needed for some of these utilization reports off the American Hospital Association annual survey. So we put into rule that this survey is the means by which we collect some of that data. And so that is due. Please complete it. This isn't this is what OHA gets. And so this is what we have a vendor, that vendor being apprised, this is what they provide for us. And so don't take this form, you know, to be inclusive of everything that you may or may not be giving to Apprise for other reasons. I just also want to make that clear. This is just what OHA needs. Next slide. So kind of some summary, important information. All hospitals are required to report their financials and community benefit information to the Oregon Health Authority. Even if you are a for-profit hospital, you do have to report what you do in community benefit. That is a CBR1 form and an audited financial form. And so all data that is not personal health information, so that excludes discharge data, all data submitted to us essentially in the aggregate becomes public when we get it. We will post it all on the website. Please be aware of that. I'm only saying that mainly to, I think, reinforce that the data submissions we get are vetted and accurate, because I know a lot of them are fairly quick and I know a lot of them are self-reported. So be aware of that. We do have a blend. We have a blend of fiscal years and we have a blend of calendar year reporting. We have 5 different fiscal years in the state. Community benefit, like we just discussed, is a fiscal year report 240 days after the end of the fiscal year, and which is why we only have partial data for 2022 at this time. Most of our reports do require disaggregation to individual hospitals. This is true for the CBR1 form, and this is true for the FR3 form. And so we need individual hospital numbers. And so I think in particular, one of the ones that are standing out to us more frequently is on our audited financial reporting form. Property, plant, and equipment is being stated for the entire health system and not for the individual hospital. And so that's an area that we need to work on a little bit. All our reporting forms and the most updated version of them, because sometimes we change them a little bit, can be found on our website. Next, I think we're done here. Next slide. I'll pause for questions if there are any. Joanne.
You're having a great day. Just a quick question about the community health improvement plans.
Certainly.
Hospitals don't do health improvement plans. We do community benefit implementation strategies as required by federal law. So what is the difference? Are we now being required to do health improvement plans? We are involved locally with our county health departments and, you know, IHNs, CCO with their improvement plans, but we are required to do that community benefit implementation strategy that follows our needs assessments.
That is correct. There is no difference. That was just my slip in using loose language. So thank you for that clarification. That is what we expected. Any other questions? If not, I think Sarah can take it from here.
Okay, so now we're going to talk about the community benefit program changes. 2 main things. First, I want to talk about the community benefit reporting 1 form, or CBR1. That is our major quantitative reporting form right now. And so we, at the moment, don't have any suggested changes we'd like to introduce, but I did want to open up the floor to see if there is anyone who would like to suggest a change to the form. And if we do have any form changes, we will finalize those by the end of September and then institute any form changes for the FY23 reporting year. So if anyone has any suggestions, we can discuss them now, or also feel free to email us at any time. Okay, I'm not hearing any suggested changes at the moment. So then I can move on to talking about our reporting. So we will be reporting on FY 2022, which means reporting on the spending for the first time this year. And how we do that every year is through our dashboard. And at the bottom right of the screen, you can see that's our little icon for the dashboard, and through our summary report. And those are both published each year in Q4 of the calendar year. And so this year that we'll be reporting on the spending for, we are going to incorporate a new tab on the dashboard that reports on individual hospital or hospital group performance against their own spending for. And then we'll also add information to our summary report. And both those reports will be available on our website under hospital reporting, and then either dashboards or community benefit. And on this slide, I have a mock-up of what the new tab on our dashboard might look like. And so as Stephen said, we only have half our data so far. This is definitely just a work in progress. It is not specifically what the final dashboard will look like. But here's an ideation of what it could look like. At the top, you can see it's listed by health system, and then the second half of the page is by individual hospital. And the first blue bar shows actual FY 2022 community benefit spending compared to the middle bar is the assigned 2022 floor. And then the lower bar for each hospital or health system is the 2023 floor. So you'll be able to see by specific hospital or health system. And then on the right, you can see different categories that you'll be able to toggle between. So that is our programmatic changes. Do we have any questions? Okay, not hearing any. Let's take a 10-minute break. So it's 10:40. Let's come back at 10:50. Okay. Okay, I think people are starting to come back from break. I'll give it another minute or so, then we can move on to part 2. Okay, it's 10:51. I'm hoping most people can filter back in now. Before we start, I want to give Stephen a chance to make a comment.
Hi, thanks, Sarah. Just I felt I made an incomplete response about adjusting the community benefits floor. One thing that I wanted to stress about it, the best opportunity to work with us to fix your spending floor is when you get that draft floor and you respond to it. That's our system. That's when it's modified. We built that into the process. And so, when you get that draft spending floor letter and you look at it and you don't think that's right or sustainable, reach out to us. And that we definitely have more opportunities for correction in that time period than after the floor is final. And so I want to make that clear. There's going to be 27-ish hospitals about to get their new spending floors here in the next couple months. And so keep that in mind. With that, I don't want to in any way make that statement to try to infer, don't reach out to us after the spending floor is final. Please do. We absolutely understand these were really hard times for hospitals. Code was tough. We know administrative staff is taxed. And there's just a lot of work and not a lot of people, around to do the work. And so OHA is going to be as flexible as it can with these spending floors. And we're going to work with hospitals as we can. I just really wanted to put that out there. It is best to do it before your final. And so just as a big reminder to everybody. Thank you.
Okay, thanks. Now we're gonna look at narrative reporting. So this is the first year for FY22 that we had required narrative reporting. So we've received a ton of questions about narratives, how they work, how they're different from other forms, what they're supposed to look like. And so this next section should hopefully answer some of those questions because we did receive a wide variety of narratives thus far. So we're hoping we can give some advice. So first, I want to differentiate how the narratives are distinct from a CHNA or a CHIP, and the CHIP being the Community Health Improvement Plan that is the same as an implementation strategy. So the CHNA is a 3-year prospective document that says, these are the health needs for my community that I'm going to look at and focus on for the next 3 years. And similarly, a CHIP or implementation strategy is another 3-year prospective document that says, these are the needs we've determined, and now here are the strategies that we are hoping to use to address those needs, and these strategies can be employed over the next 3 years. And separate from that is a narrative, which is specific to one single fiscal year, and it is a retrospective document. So within the life of a CHNA and CHIP, there will be 3 separate narratives. And so that narrative looks at what actual activities were we able to employ within a single fiscal year. We might not have been able to address every single strategy this year. Some of the strategies might not start till next year, or some of our needs might not have been able to be addressed this year. So within the lifestyle of a CHNA and CHIP, the narratives the 3 different narratives could look different for every year. So I wanted to make that distinction that there are 3 different narratives within the CHNA and CHIP. They respond to the CHNA and CHIP, but they are specific to a fiscal year and a hospital. So what are the point of the narratives? Really, our main focus of our program here is transparency. We post all of our documents online so they're available to the public, and the narrative is no different. And really a big goal is that the narratives explain the CBR1. So while the CBR1 is all the quantitative information, that other community benefit activities section is really what the narrative expands upon, and it explains all those dollar amounts. And the narrative, it's really an opportunity for hospitals to say, here's all the stuff we're doing. Here's all the programs and activities we are investing in to offer to all of our patients and community members in our service area. Here's what we're doing outside of just direct patient care, outside of health services, to help our community get healthier. So we've received a lot of questions about where can we find the narratives, how to answer them. So I'm hoping this slide, which you will get a copy of, can clear things up. You can find the narratives, which are 4 questions, 2 places, either on the first tab of the CBR1 or on the CBR1 instructions on page 17. And both the CBR1 and the instructions are available on our website, Hospital Reporting Program, under the Forms section. And then, so the first 2 questions ask, what's the most recent year of your CHNA, and what are your top health needs and demographics? So those 2 questions can largely be pulled from your CHNA. Maybe it's a copy and paste, maybe it's a copy and edit and revise so it better answers the questions. But largely that information should be consistent with your CHNA. And then for questions 3 and 4, they ask about significant community benefit activities, and then activities in social needs and social determinants of health and health equity. So that information, the quantitative information, can be pulled from your CBR, that other community benefit activities section. And then the descriptions should be pulled from your internal community benefit tracking, what you did, the hours spent, etc. So I have some examples that I want to run through of different answers to our narratives, and the narratives can look totally different. We're not being prescriptive on exactly what it has to say. They can be structured, formatted, and answered different ways. And so I'm going to go through a couple different excerpts that show you how different hospitals answered the narrative questions that we thought were strong examples. So here for question 2 that asks, what are the top health needs? And then information on geographies and demographics. This example is from Lower Umpqua. And so their first sentence answers, what are the health needs? And then after that, they go into talking about the county, cities, and then how the population is older adults and they have chronic diseases and they're in a rural area. So this is just a short 1 paragraph from their much larger narrative, but I liked how it was a succinct answer to question 2. And then oppositely, we have an answer from Southern Coos. So this is showing how you can answer the question in different ways. So whereas the last one just gave all of the needs and then about the demographics, Southern Coos chose to highlight a need and then do the demographics under each need. And so they separated out in their whole narrative, but here they say one of their top needs is social determinants of health. And then they go on to describe the population and how they're affected by that need. And then for question 3, we have, what are the significant community benefit activities? And so St. Alphonsus, Baker City, organized theirs by their different needs, and their top needs are health care access, education, and transportation. And what I liked here is that they separated question 3 away from question 4. So as you're reading through the larger narrative, you can tell what are the significant community benefit activities, and they're differentiated from the social needs and social determinants of health. And one thing I would consider adding to make the strongest narrative would be information about dollar amounts. So how connecting the narrative to the CBR1, and then also including amount of people served, hours of service donated, and what the program impact was. Really focusing on showing the whole picture. And so before we move into talking about question 4, we have received a lot of questions and different answers for how to talk about the social needs versus social determinants of health. And so another program within OHA put out this definition that I really liked and wanted to share, because it says that sometimes social needs and social determinants of health are used interchangeably, but they're not the same. Social needs are social and economic needs of an individual that affect their ability to maintain their health, versus social determinants refer to conditions in which people or populations are born, live, work, etc. So really social determinants are that population level thing that affects an entire population, versus social need can be seen as the result of a social determinant of health, and it's much more individualistic. And so social needs are where we see a lot of the programming and activities that hospitals do. It is largely in the social needs, and OHA does understand that, you know, social determinants of health is where we would like to go. It's where we would like to see funding and collaboration and movement. That might not be where we're at right now, but it is our focus and where we would like to incentivize hospitals moving towards. So I'm going to show some examples of what hospitals are doing for both of those. So for social needs, we have an excerpt from Salem Health, and they talk about 2 grants that they did, Union Gospel Mission and Church at the Park. So they have a description of what both of those grants were for, a medical clinic, hiring coordinators. And then I really liked how they talked about the amount of people served, 3,000 visits for 30 individuals. And then they talk about the impact and what the difference made by that grant was. So it reduced emergency visits and number of 911 calls. And then for part 2, that is addressing social determinants of health, systemic issues, and health equity. We've got 2 examples. Sky Lakes, so they talk about the social determinants of health being the environment. So they funded hiking trails, a park, a bike lane, a play area. So those are things that really impact an environment and a family or a population's ability to thrive and be healthy, be outside, transportation, and like getting to different places. And so I really liked how they had, again, a short description and sorry, my cat is moving around. A short description, and then talking about all of the changes they made. And then Legacy Health, similarly, talked about a grant they did for Emerging Leaders Internship Program. And they talk about how many applicants were impacted and that they were able to get leadership track internships. So that's talking about the impact. So again, these are really great examples that can be seen. All of these are on our website, on our hospital profiles pages. We post all of the documents for every single hospital. And again, I think really strong ties to the CBR with dollar amounts, hour amounts. Those are really our top examples. So now I'm going to shift from talking about your reporting to OHA's reporting. So OHA will be putting out a summary report of the narratives that are reported to us. publishing early 2024, and then it will become an annual report. And this report is going to highlight those hospitals that are doing the most to positively impact community health, especially in prioritized areas of needs. So this is a qualitative report. Since we have our quantitative report already, the dashboard and summary report, so this will be a new additional report that really focuses on that proactive direct spending. And the structure of the report will be by prioritized need. And even though we are very diverse throughout the state, we have a lot of shared needs. For example, behavioral health, affordable housing, and access to care are 3 needs that pop up on almost every single narrative. So we'll be talking about those shared needs statewide, and then within each need, we will be highlighting those top hospital programs or investments for each need. And when I say top program, it's not necessarily the hospital that's giving the most money. We're not going to be comparing DRGs to type A's. We're going to separate that out and really use the narratives that are provided to us to tell those stories that are told best about making the biggest impact in the community, and in a place that has the most need. So do we have any questions before we move on? Okay, not hearing any. I will give it to Stephen to talk about the new legislation.
Awesome, thank you. Next slide. So I'm going to be talking very briefly and fairly generally about this bill and kind of about really the high level plans. I think generally about what the process OHA will go through. Largely speaking, because the ink is barely dried on this bill. And so, as a program, we've not sat down for detailed planning or anything like that. So, just a little caveat before we really get into it. And so House Bill 3320 changed a lot of, essentially a lot of aspects around financial assistance policies that hospitals have to have. And so just kind of in brief, this isn't, exhaustive, but sort of the high marks. It's going to create a pre-screening requirement and scoping criteria for that financial assistance. And so OHA is going to have to be doing rules around this process where hospitals have to create, a pre-screening eligibility for hospitals, which essentially makes them avoid attempts to, send to collections until their financial assistance eligibility can be determined for certain. And so it creates some changes around the collections process. And by that, we mean, the technical term, the extraordinary collection actions. It expands the amount of time that patients have to apply for their financial assistance. It creates some language around using plain language, increased visibility of financial assistance policies online, and allows for financial assistance applications to be submitted online. It does clarify what information can and cannot be used for determining financial assistance and requires that those items be very clearly marked what is required and what is optional to report. And it's going to add some regulations and create some new reporting for OHA to collect. Next slide. And so generally speaking, OHA is going to do rulemaking on a couple of the things that are called out specifically for OHA to create rulemaking on. That is essentially 3 areas. That's the appeals process, that's the financial assistance, and that is guidance for the pre-screening process. We will have the administrative rules stood up prior to the effective date of each of these provisions. And so for the appeals process, for financial assistance, denials, and for the reporting form, those effective dates are out in January. The pre-screening eligibility starts July 1st, 2024. And so we'll have rules set up prior to that. What that probably means, not for certain, but what it probably means is we will stand up all the rules by July 1, because we don't want to have multiple rule advisory committees and keep pulling you back in, especially on a fairly tight turnaround between July 1 and January 1. It doesn't mean they'll become effective when we stand up rules. It just means we're going to get the rules probably done by then. More details, OHA will communicate, more details as we start finalizing our plans about exactly how we're going to go about doing this. But largely speaking, we're going to do the same process that we did to stand up the House Bill 3076 rules, which I think a lot of people on this call were probably involved with. And that was a fairly big lift. That was a lot of rules that we had to do with some heavy material. And I think OHA and partners came together very well to put out some pretty strong rules on that. So I think we're going to do the same thing again. And so that starts that we're going to engage with everybody here, with all the partners and parties pertinent to this bill. And then we're going to have conversations with them just to gain their share understanding about what the bill requires, their expectations, and kind of what they want to see around rules. And we're going to take all these expectations. We're kind of going to get an idea of what we want to write and rule. And then we're going to consult with our DOJ. And our DOJ is going to give us kind of a framework and a guidance about what we can and can't do in administrative rules and where those boundaries really are. After we get that clear understanding, we'll actually, put pen to paper, write up some draft rules, and again, go out to some of the partners just to make sure that we're kind of in the same ballpark before we start that Rules Advisory Committee. I'm sorry if my camera looks like it's going crazy here. Sorry, y'all. And that'll be it. And then, once we feel that we're in a really good place with these rules, we'll start the actual formal Rules Advisory Committee process. It's our belief that we should start the process with draft rules that exist, such that the hospitals and people as a part of the RAC have something to respond to and edit from. And so that's what we'll be going on that. Obviously, if you want to be a part of it, we'll send out broad communications to invite people to participate in this process, and then we'll be communicating with you actively to make sure. I'm going to turn my video off. It's bugging me. It's probably bugging you. Yeah, we'll reach out and be sure to be engaging with you as we move forward in this process. So any questions or comments on House Bill 3320? Such that I can answer them at this time. Yeah, Elizabeth.
Hey, thanks so much. Elizabeth Edwards with Kaiser Permanente. I guess just if you had any sense of the ballpark timing for when the RAC would get stood up, and any buffer that could exist between when the rules go, having a rough sense of the rules, and when we actually need to implement that presumptive screening. It's something that takes some time to build into our system. And so if we get the rules on July 1 and it's effective on July 1, that's challenging.
Yeah, absolutely. That's a great question. I think it will be, every bit of OHA's goal to have the rules stood up, well in advance of that July 1 timeframe. I think for certain, what I could give you in a rough idea is there is a delay after you hit final on the rules and you send it through the Secretary of State process. That actually takes a little bit of time. So the rules as such is that they're going to be posted and finalized will be known for, I don't want to misstate, but roughly a month or so prior to when they actually become effective. And so I think you can count on having a pretty firm scoping of what those rules are going to look like. I'm going to wager there in the March, April, May, probably no later. Well, it couldn't be any later than May. And so hopefully by April, you're going to have a really solid sense of what those rules, especially for the pre-screening portion of it, would look like, would be my expectation.
Yeah,
and then again,
the earlier the better on that.
Yep. No, we understand. Any other questions? If there are none, we can go to the next slide. Are there any questions on anything?
Hi, Stephen. This is Jeff Winkley from Apprise Health Insights.
Hi, Jeff.
I had a question, just thinking back to the comments made earlier by Eli and Curry Health and their situation with their spending floor. And also hearing from you that you're able to work with them given their unsustainable increase in their spending floor from the results of the formula, that OHA can work with them. But do you think there is a way or envision any changes to the spending floor calculation itself to maybe smooth out these huge increases, or ways to create like off ramps for those hospitals that are under like sustained negative margins? Do you think those can be built into the formula at any point, or do you think working with hospitals one-on-one is what OHA is kind of their strategy at this point?
Yeah, thanks for the question, Jeff. That's a great one. I think absolutely there's potential to address our methodology to better adapt to this time period. For sure. This is why we have the summit. This is the exact reason for the summit, is to review what's going on and take a look at the methodology and make sure that it's working for people. I think the challenge that we face, of course, is because of the lag in our data reporting, because of where we're sitting at, it makes it a little bit difficult to make timely calls and put a process into play to get a spending floor modified quickly. And so what I would say to that is, as we are going to take it right now in the here and now for the spending floors that are kind of are coming up, we're very happy to work with each and every single hospital one-on-one to make sure that we can fit the spending floor to what we really think is going to be the true trend of their unreimbursed care. I think, given we still have half the hospital spending floors, we need to get their data, we need to assign their floors. If we come out of this first spending floor and we realize we basically had to go through and modify, half our hospital spending floors anyways, then I think next year, our conversation is we need to take a look at this methodology directly. And so that's where I predict now. I think, Joe and then Trilby.
Hi, this is Joe Richter, Senior Director for Community Health Investment for Providence, Oregon. Just a comment and a quick question. The way that you guys have framed the narratives has been really helpful. I know we've gone back and forth with a lot of concern over the guidance on those and how we were going to accommodate those without overwhelming you with hundreds of pages of text. But the one thing I am a little concerned about still is what is the public guidance for those narratives in terms of what is someone going to see that says, this is how people are supposed to be reporting this, and this is what they reported. I know that, in conversation, the leeway there is fantastic, but I just want to make sure that the guidance, that whatever the public guidance is aligned with that flexibility. And I have to admit, I haven't looked at it recently, so I don't know if it's changed at all, but I'd just like to make sure that what we're saying in this meeting in terms of that kind of breadth and options is reflected in the guidance.
Yeah, thanks, Joe. I think that's a great comment. Also, I think what we can at OHA commit to, especially as we get the first year of fully actual and required narratives turned into us, again, is about half the hospitals still have to do. We can take a look at where we're at compared to kind of where we've advised. And I think primarily we would turn back to our CBR instruction document, which already contains a little bit of the guidance, and look for where we can improve in those guidelines and make sure that we have a very public source of, and a transparent set of guidelines and the points like we've made earlier in the slide. And that's in an established and well-known document that all parties can access. Trilby?
Thanks, Stephen. Yeah, just to comment briefly on what Joe said, I think it's going to be important also in the report that we put out to be transparent and frame this in a way that makes it clear what it is that we asked for from hospitals in the reporting. So that will be really important. And then I just want to reflect a little bit on what Jeff was saying about, will there be an opportunity to revisit the formula? And I appreciate, as Stephen put it, the time frame for that and thinking about how many requests did we get to reset floors. And the other side of that is we will be working with individual hospitals to really take a look at how things have been reported this last year. This big spike that we saw, making sure, like as Stephen noted, we're seeing that losses on Medicaid are climbing at a faster rate than actual claims for Medicaid. So, what's going on there? Is there some adjustments to reporting that might kind of stabilize the spending and make it more real, more meaningful? And then that helps with how the floors get set, because they're set based on what the spending has looked like. And the other piece of spending that I think could bear some discussion, or the reports on spending, is the subsidized health services category, and just kind of digging into that and seeing whether some losses are being transferred over there that are really more appropriate to be reported elsewhere. So I think that there's two sides of really addressing what's happening with floors moving forward. Part of it is really looking at the revenue and the ability of the hospital. And then the other is, how has the hospital been reporting on its spending? And is some of that, could some of that be more accurate? Just want to make sure to make that point.
Thank you for that. Any other questions or comments? I do not think, as they're coming up, I don't think anybody has signed up for public comments that we've been made aware of. Is that true, OHA staff? Nobody's received anything. I will, as it relates to that, as Sarah said before, if you do have comments you want to make, you can make them now, or we're always happy to take any email, letter, or otherwise, and put it on our website if you have comments about this program. Very happy to do that. One of our principal values in all this program is the transparency of all of it, and it's something that we hold in high regard, for sure. We got a few minutes left, so I don't want to shut the door on anybody, but I am respectful of everybody's time, so I'll linger for just a minute or two if any other questions pop up. In the meantime, Sarah put our contact information on this last slide, so anything to do with community benefit or hospital reporting at large, there's all our contact information. Sarah Gravy is our community benefit program lead. I am the overall program manager. Rachel's our data analyst. So some technical questions if you have about some of the form reporting, she can work on. And then of course, we just have a general program inbox, usually where we direct the reporting to there below. Oh, you know what? I did. Eli, sorry, Eli, we have a question. We have a question. I already said it. Eli from $4 asked a question if I could go over how unreimbursed Medicaid is actually calculated. And I think that's a pretty good question. And so basically the system that is used, it's a replication of the system that is used on the IRS on the Schedule H form. And what it does is it uses the gross charge. Well, you have two options, but I'll start with the way that most everybody does it. It's you have a system of estimating the costs that are associated with Medicaid by using what's called a cost charge ratio. And so a cost charge ratio looks at the total amount that you billed for services as a gross charge. This does not account for contractual allowance, does not account for actual reimbursement received yet. And then you compare that to your total operating expenses. And the ratio of those two things is what we call the cost charge ratio. And what that represents is effectively for every $1 I charge for my services at a hospital, I have this amount of operating expense. And there is a very wide range amongst hospitals in the state as to what that relates to. This is used to then estimate what the costs are incurred on the Medicaid side. So then, knowing roughly how much operating expense you incur for every $1 you charge, you then specifically take the amount of money you charged for Medicaid services, and then you multiply that by the cost charge ratio. And so, if it was $1 million in gross charges and your cost charge ratio was 0.5, what you would result in is, $500,000 in costs. And so that's how you establish how much Medicaid services cost you. And then on the other side, you then actually report your actual revenue. So how much money you really did receive for providing those services. And then so if your costs are greater than the money you actually received, then that's what you state is unreimbursed care. So that was a very high level overview of it. If you look at our reporting form, you see some of the more details. If anybody needs, I think, a little bit more deep dive or closer, more detailed explanation of what it really means, we're always happy to have meetings, to meet face to face, go over this stuff, provide guidance, provide advice, do anything. We're all at your service as it relates to this type of thing. So, all right. I think with that, we'll close this meeting down.
Okay, thank you everyone so much. Have a great afternoon.